So thank you everyone for joining our weekly Fireside Chat. Today we are going to have a Fireside Chat number 191, and I would like to welcome our speaker back, Prof. Cullis. He was one of the moderators for one of our PD sessions last year, so welcome back, Prof. But before you go ahead, I would like to just briefly introduce you to the audience. So Prof. Cullis is a nephrologist and a specialist in intensive care physician at Hilton Life Hospital, and is an honorary associate professor of adult and pediatric nephrology at the University of Cape Town. He has a keen interest in intensive care nephrology, especially peritoneal dialysis for AKI, and is a primary author for both editions of the ISPD guidelines for PD in AKI. His other interest is development of programs in low-resource countries, having set up a nurse-led PD program in South Africa, being a principal investigator in the ISM Kidney Care Network study, and is the chair of the Saving Young Life Steering Committee. He is the co-author of the ISPD guidelines for PD access and the current PD catheter infection guideline. He is the president-elect of the ISPD and sits on the ISN core program committee, ISN regional board, ISN dialysis working group, and ISN WHO AKI and dialysis toolkit development group. And the Prof is going to take us through dialysis, but outside the box. So welcome, Prof. The floor is yours.
Thank you very much for that kind introduction, Michelle. So I'm going to talk about just some out-of-the-box thinking with dialysis. We always talk about what sort of patients with AKI in the ICU, and that's a whole topic in itself. But I'm going to just look at some of the other things that are maybe not mainstream in terms of dialysis in the ICU or extracorporeal therapy in the ICU, and just talk about them. What's really important, I think, is that so often with our intensive care colleagues is the belief that a dialysis machine and the kidneys are equivalent. So there's no worry if we lose our residual kidney function, the patients are going to do just as well if we just put them onto a dialysis machine. And so often I have to try and sort of persuade my colleagues not to immediately put a patient onto dialysis because it may do them more harm than good. Remember that our kidneys are living organisms. We have glomeruli, which are able to adjust. They're able to control how much protein we've got through, how much filtration we make. And we compare that on the right-hand side to a hollow fiber membrane, which is essentially just a small sieve. Although there's size selectivity, there's really no living control of what's going through it. And then once we've made our filtrate in our kidneys, we can actually absorb what we need. We absorb all sorts of solute, but importantly, we absorb things like our antibiotics, various proteins, insulin's metabolized there. Whereas in a dialysis machine, all that we do is we give a fluid which contains a little bit of salt water and some sugar, and that is given back to the patient, trying to equate to what we would do in our tubules. And then even things like our TAM Horsfeld protein is important. So in these septic mice, it's quite interesting. If they knock out the ability to create TAM Horsfeld protein, you can see that in mice that the levels of interferon gamma, interleukin 1 and TNF alpha are significantly elevated in those without the ability to produce TAM Horsfeld protein. So the kidney actually has an impact on controlling cytokine storms, things like that. So really we need to think of our kidneys as the gold standard, and dialysis is an alternative which we'll use in an emergency situation. But so often the feeling from all of our colleagues is that dialysis is this magic thing, which is actually even better than our kidneys. The reason that this happens is that we know that in patients with sepsis, there are a huge number of cytokines that are produced. We've got lipopolysaccharide that's circulating, that stimulates a whole host of cytokine production. We get cell-free DNA floating around. We get reactive oxygen species. We actually have bacteria floating around even. And the feeling is that if we can mop all those things up, then we can make our patients better. And certainly this is, it is true. If we could limit the inflammatory response, that would be great. Our patients wouldn't do so badly. And this is very much what our intensivists and my colleagues thought about this idea of high volume filtration during sepsis. And I started my ICU career in the 2000s, right at the beginning, and it was a standard of care that the patient that came in through the intensive care unit, they got stuck on a hemofiltration machine, because you were going to be able to wash out all those nasty things that were causing sepsis. And we tried to filter out all of the cytokines. The problem is that sepsis is not just a one-sided disease. So yes, there are all of these inflammatory cytokines, there's complement activation, there's activation of the coagulation system. And if we could dampen that down, it might certainly have an impact on how patients do. But the problem is that we also have a yin and yang. We've got an anti-inflammatory component as well. And these anti-inflammatory cytokines they are there to dampen down this response. And if we filter out these patients non-selectively, not only are we taking away the bad stuff, but we also are potentially taking away the good stuff. And so, all of the therapies that we have are very non-selective. And so we may be doing more harm than good. Now, in terms of high volume filtration in sepsis, this was just looking at patients. They put them onto hemofiltration at high volume for 12 hours, and then they would change the filter at 12 hours and carry on. And what you can see on the left-hand side is in the top block is TNF-alpha, interleukin-1 beta, and interleukin-6. And the white part of the bar is how much of that cytokine was filtered. And then the gray, the various shades of gray and the black were the amount of the cytokine that was actually adsorbed onto the membrane. So a lot of what the clearance that's happening in our hemofiltration membranes, or the clearance that's happening for cytokines, is actually through adsorption, where it actually sticks to the membrane rather than necessarily filtration, because you can see that the proportion of clearance, certainly early on when the membrane is new and clean, is actually adsorption. Very little of it is filtration. And you can see on the right-hand side, if you look at the concentration of these cytokines, you can see that over time they start to climb. And then if you change the membrane after 12 hours, it does seem to cause a little bit of an improvement, but then they climb again. But what's worrying is that over that 24-hour period, what do you see with the general trend of these cytokines is actually that although there's a drop at 12 hours, the overall thing is that there is an increase in cytokines, despite these patients being on high volume filtration. So high volume filtration certainly doesn't seem to create a downward trajectory of these cytokines. And this is two studies that were done. The one on the left was done in Australia, and they took patients who didn't need dialysis for renal indications, but had sepsis. And they randomized them to either control or to hemofiltration, with the idea that you would remove these cytokines. And what you can see is that on the left-hand side, in the Australian study, that actually there was no difference in cytokine levels in the groups that were hemofiltered compared to the groups that were in the control group. And on the right, Didier Payen's group in France, they did a similar study. Again, they showed no significant difference in IL-6 levels in the patients that were hemofiltered. So you certainly didn't drop the level of IL-6. But what they did show was that actually the patients worsened in terms of their organ failure score, and there was a trend towards worsening survival in those patients that were filtered. So what was happening is that actually we may be doing more harm to these patients, exposing them to some sort of hemofiltration. And we taught in medicine, first do no harm. So we need to make sure that if we're offering a therapy, yes, sure, it might be theoretically a good treatment, but we need to make sure that there's not an added side effect that's actually overall going to cause harm. And why might hemofiltration or any extracorporeal therapy lead to harm? Well, our dialysis membrane, our extracorporeal circuit, is foreign. It's foreign to our blood. And there's very good evidence that exposure to a dialysis membrane increases your complement activation. Complement activation obviously leads to neutrophil expression, and that stimulates your inflammatory response. It stimulates your coagulation cascade. So we've got a patient who's already inflamed, and we're making it worse. We're exposing them to an extracorporeal circuit. Not only do we get that, we get this leukocyte adhesion to the membranes that leads to an increase in, again, the complement cascade. We get increase in coagulation, and that coagulation doesn't only occur in the membrane and in our dialysis filter, it happens throughout the body. And a lot of the problem that we see with patients with sepsis is that in the microvasculature, the big problem is that they get these small clots or micro thrombi that are forming that lead to poor perfusion in the peripheries and in the capillary beds. So we don't want to do something that's going to stimulate that even more. The other thing is that we know from our chronic patients that being on dialysis leads to myocardial stunning. And this has been shown looking at regional wall motion abnormalities with echocardiography in patients on chronic dialysis. But they have also looked at it this was in the UK, they were looking at patients who were in the ICU who had acute kidney injury. These were patients who were not on inotropes. They were, so theoretically had reasonable cardiac function. And yet you can see that significant numbers of them developed regional wall motion abnormalities, and they had worsening of their cardiac output associated with being on intermittent hemodialysis. And then when they looked at patients on CRRT, because CRRT is supposedly cardiovascularly stable, you can see again that by 24 hours, there was a significant increase in the number of patients who had myocardial stunning in terms of decreased myocardial function. And that's despite these patients having similar blood pressures. So even though the blood pressure may not be falling, we are having an impact on perfusion in the myocardium. And I'll just remind you that it's been shown that in peritoneal dialysis patients, there's no evidence of myocardial stunning. Just looking on the left-hand side, this is a study that was done in France where they randomized patients to either intermittent hemodialysis or continuous veno-venous hemofiltration. So CRRT versus IHD. And what they showed was that actually the incidence of hypotension was no different between the two groups. So significant numbers of patients developed hypotension, whether you're on intermittent hemodialysis or CVVH. Now, these are patients with acute kidney injury, but CRRT is not as necessarily cardiovascularly stable. You're getting as much hypotension as you are with intermittent hemodialysis. If you look on the right-hand side, there's two studies for looking at peritoneal dialysis, and I'll talk about it a little bit later. The one from Thailand and the bottom one from Saudi. But you can see that hypotension significantly lower in the PD patients compared to those patients that were on extracorporeal therapies, whether that's CVVHDF or IHD. And so hemodynamic instability is actually less of a problem with PD, and we'll talk about that later. But I'm just going to come back to this idea of a high volume filtration and its action in septic shock. So this was a pivotal paper from 2006, and it was presented all over the world. And because it was from Claudia Ronco, everyone felt that this was gospel, that this is what we should be doing. And what they looked at was patients who came in with sepsis, and they got 12 hours of high volume hemofiltration at about 45 mils per kg per hour, and then dropped to 20 mils per kg per hour. And they looked at survival. And you can see that those that got high volume hemofiltration, which are the top group, had a much better survival compared to their the control group. The problem is that this is actually a retrospective study, and they compared it to a historical control group. It was not a randomized control trial. And the problem is that the patients in the control group were only the patients that were filtered due to the fact that they developed acute kidney injury, which was very different to the group that were hemofiltered early on in sepsis. So their survival was likely to be different. And this is a sign of lead time bias. But it was what got people sort of thinking, well, maybe we need to do this high volume filtration and we can make people better. So the same group did this early study looking at hemofiltration. This is in patients with AKI, with sepsis in the ICU. And they randomized them to a filtration rate of 15 mils per kg, 25 mils per kg, or 30 mils per kg per hour. And what they showed was that your survival was relatively similar if you're in group 2 or group 3, so between 25 and 30, whereas group 1, who were 15, they had significantly lower survival. So it did seem like there was a threshold above which you got some improvement if you filtered these patients more. So this was followed by 2 large randomized controlled trials, multi-center randomized controlled trials, the VA study done in the US. This was looking at high intensity versus low intensity dialysis in critically ill patients. There was a split between intermittent hemodialysis and CRRT. So there were 2 groups in this study. But what they showed was that aiming for 35 mils per kg per hour or 25 mils per kg per hour, there was no difference in survival between these groups. So aiming for this very high volume of filtration didn't seem to have a benefit on survival. And when you look at the subgroup analysis, in this study at least, if you were in the sepsis group, it seemed like the less intensive group actually were trending towards doing better, although there was no significance between this. It was a bit worrying because that was the group you thought would do best if they had a high volume filtration. Pretty much the same month, the renal trial from Australia and New Zealand came out. This was where patients were also high volume hemofiltration, 35 versus 25 mils per kg per hour, and they looked at their survival. This was all CRRT. Again, there was no difference in survival between the 2 groups, whether you're high volume or not. Although in this group, if you had criteria for sepsis, there was maybe a trend towards a benefit in these patients. But again, no clear sign that aiming high helped. This was the AVOIR study where they actually randomized patients to 70 mils per kg per hour, compared that to 35 mils per kg per hour. But again, no difference in mortality at 60 or 90 days, no difference in catecholamine free days, and no difference pretty much in anything in this group, apart from a SAPS-2 score at day 4. So aiming high doesn't seem to make any difference to outcomes. And a Cochrane review looked at all of this, and they came out saying that there's really no clear evidence that high volume filtration is beneficial in severe sepsis with septic shock, and there's no evidence to support its use. So I showed you the kidneys are gold standard. CKRT is not as good, and this is what people think of PD, is that it really is horrible. But this is out of the box because we're not using the box at the bedside. We're using the patient's own peritoneum as a modality for dialysis. And so there've been a number of controversies. Is PD able to achieve adequate clearances? Can it be used for critically ill ICU patients? Does PD have outcomes which are equivalent to other extracorporeal therapies or better? And are there any benefits that may make PD slightly more attractive in certain settings? So just going back to that VA study, the American study that I showed you, if you look at the ability to what sort of clearances they achieved a weekly KT/V of around about 2.1. And if you compare that to the patients on PD, that's really what we should be aiming for, a KT/V of 2.1. Well, actually, you can achieve very high clearances with PD. The study from Daniela Ponce in Brazil showed that you can actually get clearances of up to KT/Vs of 4.1, so double what was achieved in that VA study. So certainly PD is able to achieve adequate clearances if you're looking at urea, but there's a number of potential advantages, certainly for us in Africa. Obviously, the cost and minimal infrastructure that we need, the lack of water, the fact that it's locally available. But really, I showed you earlier, the cardiovascular stability, I think, is really important because many of us don't have access to CKRT, although whether it's better or not is up for debate. But certainly for the patient who is cardiovascularly unstable, this might be where, for us, it really has a big role to play. Certainly, it's very important for kids because of the lack of need for vascular access. And as I showed you, the extracorporeal circuit is bioincompatible, whereas PD, we have our own compatible membrane. And this is important, and there's a meta-analysis that's about to come out soon, showing that resolution of acute kidney injury does seem to occur at least much earlier in patients on PD compared to other forms of extracorporeal therapy, on average about 3 days earlier. And in terms of survival, there's no difference in survival in this randomized controlled trial from Brazil. This meta-analysis looking at retrospective studies, and we looked at it in the ISPD guidelines and showed that there's grade 1B evidence that it is as good as other extracorporeal therapies. The Cochrane collaboration comes up with the same conclusion, again based on this moderate level of evidence that for mortality and recovery of kidney function, there's little difference between the two. What's important is that it's still good enough in the patient with septic AKI. And that's what I just wanted to show you in this slide, where you can see that these are the studies that were done in Brazil, the Saudi, and in Thailand, showing that patients, up to 85% of patients ventilated, high Apache 2 scores, that outcomes are equivalent between the two groups. This is the Saudi study actually showing survival was better in the APD group compared to CRRT. And this is a study that recently published in CJASN from Thailand, comparing IHD, but at a good level compared to acute PD, showing survival was no different between the two groups. But actually dialysis-free survival at 28 days was significantly better in the PD group compared to the hemodialysis group. So it wasn't, we've used it a lot in Africa because we are a low resource setting, but COVID did bring out the best in all of us. And you can see that in the US and in the UK, there was suddenly this increase in the use of acute PD because of the problems with clotting, the lack of dialysis resources. And suddenly it became slightly more fashionable to do acute PD. And when they looked at survival rates, actually what was interesting, although this was all non-randomized data, survival seemed to actually be quite good in those patients who are on PD compared to extracorporeal therapies. So just talking about yet another out-of-the-box thinking for our patients in the ICU who've got AKI. So high volume filtration, not a great idea. There does seem to be a lower threshold at which we must aim above, and that's a clearance in our patients with AKI of somewhere above 22 mils per kg per hour. But aiming higher than that doesn't seem to have any benefit. So what about other therapies that are available? Because there's some relatively exciting ideas as to what we could do for our patients with septic shock. And then I talked to you about heme adsorption, that the dialysis membrane absorbs quite a lot of the cytokines. And these are some filters that are developed where you pass the blood past these large beads. The beads create a hydrophobic bond with middle molecules and are able to extract them and retain them, so that the filtrate that's returned obviously has had that reduced. So the top one is the cytosorb membrane. There's a couple of different types. There's HA144. And then the bottom is polymyxin B. Polymyxin B binds lipopolysaccharide preferentially. So that's why it's been used as an adsorptive surface. So polymyxin B has been used actually for quite a long time. Trials going back to the 1990s. And this is a meta-analysis looking at outcomes. And certainly, if you put all the trials together, there did seem to be a benefit for polymyxin B in terms of being better than control. But actually, if you take the trials out that had a low risk of bias, unfortunately, it actually favored the controls. And if you looked at the more recent trials, where there's been quite a lot of advance in the way we manage patients on ICU, certainly there didn't seem to be as much of a benefit. And when they looked at the trials from Europe and USA, there again didn't seem to be any benefit for polymyxin B. So polymyxin B has kind of fallen by the wayside a little bit, although I'll talk about where it might be coming back in later on. What about cytosorb? So cytosorb's very heavily marketed. It's it goes into a standard CVVH circuit, and it is used in patients with sepsis as the sort of the thought process to try and mop up all these cytokines. And again, you can see in this meta-analysis that unfortunately, when you look at the studies of sepsis at the top, there seems to be no benefit. When you look at cardiac bypass patients, again, there's no significant benefit. When you look at severe illness, no significant benefit. And in COVID, actually, there seemed to be a risk of harm. So if you just looked at the randomized controlled trials, so that was all studies. If you look at randomized controlled trials, again, unfortunately, it seems like there is more trend towards harm rather than a trend towards good. And again, this might have something to do with the fact that we're exposing these patients to an extracorporeal circuit when they don't need to be exposed to it. This is from the COVID studies. So the top one was in Lancet. And you can see that there was actually, although there was a reduction in the amount of serum interleukin-6 after 72 hours, so it seems to make sense. It's going to make these patients better. Actually, 30-day survival was significantly higher in the control group compared to the cytosorb arm. And again, another randomized control trial also showed no difference in the need for vasopressors. There was no difference in discharge from ICU and no difference in survival. And on the right-hand side, you can see again, the cytosorb group actually seemed to have a trend towards worsened survival rather than better survival. The one place that cytosorb might be useful is in patients with rhabdomyolysis. It is very good at binding myoglobin. Unfortunately, though, we still don't have any data to say that it improves outcome. So again, it's theoretically beneficial because it does have a major effect on mopping up the myoglobin. But we still don't have randomized controlled data evidence to show that it actually improves outcome or recovery of kidney injury. So although it's been recommended by the Rhabdomyolysis Task Force, we still don't have enough evidence for it. The other place that cytosorb might be beneficial for is rivaroxaban. It does bind rivaroxaban, so it could be used in patients who have significant bleeding associated with NOACs. Might be an option. So that's hemadsorption. What about plasma exchange? So plasma exchange is where we take the plasma, we filter it out, and we replace it either with fresh frozen plasma, freeze-dried plasma, or alternatively human albumin solution. And the idea behind this, again, is that you are taking out all the nasty things, and you are you're making the patients better because you're replacing it with clean plasma. Now, this is a paper which actually published in the last couple of weeks, and this is looking at the Exchange-1 trial. This is a trial where patients were randomized within 24 hours of sepsis to plasma exchange. They had plasma exchange with 12 units of fresh frozen plasma, just a single exchange, and then they carried on with standard of care. And what they did show was that norepinephrine doses went down compared to the control, although they did start higher and sort of come back towards baseline. But what they showed was that in patients who had very high levels of cell-free DNA, those were the group who did very well. So it's just a sign that maybe we need to be targeting specific molecules rather than just a blunderbuss approach at plasma exchange. But there are a few studies looking at plasma exchange, some randomized controlled trials. They are small studies. They're quite old studies, quite a lot of heterogeneity. But you can see on the left-hand side in the randomized controlled trials in adults, there was actually a benefit of plasma exchange in sepsis compared to control. That was not seen in children. And if you looked at those adult studies, where the benefit was those that were using FFP as the replacement solution, whereas if you used FFP and albumin, you didn't see the benefit. And what this raises the question is that when you're doing plasma exchange, you're taking away those cytokines and everything, but you're replacing it with fresh, healthy plasma. So you may well still be replacing those anti-inflammatory molecules that you do need for these patients. So you're not removing all the good stuff with the bad. Unfortunately, in COVID, we tried it quite a lot in COVID. We never saw a clear benefit. There were a few retrospective studies that suggested it was better, but unfortunately, overall, although it did improve need for noradrenaline, again, no significant difference in terms of 35-day mortality. That's plasma exchange. What about other membranes? So this is the Oxiris membrane. This is an AN69 membrane, which has got positive charge coating. And this binds endotoxin and large molecular weight substances. It certainly does bind lipopolysaccharide. And what's nice about this is that you can use this as your standard dialyzer. So when you're talking about plasma exchange, or you're talking about cytosorb or hemadsorption, there you're using it just to treat the patient's sepsis. You're not, and that you're exposing them to the extracorporeal circuit for that. What the advantage of this membrane is that if you have got a patient who needs filtration because they've got acute kidney injury, in that setting, you then have a dialyzer membrane that is able to absorb these things. So it might be beneficial in our patients who are needing CVVH. I wouldn't use it just to treat a patient with sepsis, but if in my patient who has got sepsis, this might well be a bit of a game changer in terms of outcomes. It does reduce interleukin-6 and TNF-alpha, does improve vasopressor responses. This is a very, it's not a great study. There's a lot of baseline variability, but this is taken from a study in China showing that those patients that were on the Oxiris group did have a reduction in their APACHE-2 scores, and a trend towards improved survival, albeit non-significant at all. And this is a meta-analysis published a year and a half ago, looking at Oxiris and the various studies. Again, the problem with meta-analyses, if you've got poor studies going in, your results are up for debate. And these are all fairly poor studies, but there does seem to be a trend towards a beneficial outcome. Certainly, in terms of 28-day mortality, there was a benefit in survival. But again, is it worth the cost of these types of membranes? That's really up for debate, and I think we need bigger studies to confirm it. If you have it available and you've got all the money in the world, certainly what a great idea. This is just a very busy slide looking at the different options of extracorporeal therapy and sepsis. And what you can see down the right-hand side is the quality or certainty of evidence. And it's pretty much very low in every group. Unfortunately, we don't have big randomized controlled trials in these areas. I think partly because people are trying multiple different things, as opposed to a big group like the Australia-New Zealand group, who are very good at running big trials, following down one pathway. Having said that, there are two plasma exchange trials which have recently been launched, one in Europe and one in Australia and New Zealand. So certainly from a plasma exchange point of view, we hopefully will get some answers on that. Just again, looking at the effects. So again, this is low quality evidence, but just looking at which of the different extracorporeal methods we could maybe think of using. As you can see, polymyxin B came out in favor of intervention. I showed you that other meta-analysis, but when you look at good studies, unfortunately, that's lost. But plasma exchange does seem to come out as having some benefit. Just be careful of what you read. So this is a review that's was published at the end of last year in Critical Care, and it's touted as a a consensus statement from they call themselves the Expert Scientific Group on Extracorporeal Therapy in Europe, but it is a very small group of people, as you can see, and they came out with these guidance, and this, you can see this picture suggesting that if patients have septic shock, you should be using these agents if they've got a surface score above 10, they're needing vasopressors, their lactates above 12, and you should start it within 12 hours, and then you should change the sorbents every 12 hours. And there've been a lot of letters written into this, and certainly editorial comment that they've put this forward, but it's actually based on no quality evidence. So it's their idea of what might be a good idea, but unfortunately, there's actually no evidence for any of the things they're suggesting. And for example, it's actually been shown that in patients who had lactates above 6, they did worse with sorbent treatment compared to those with lactates below 6. So just be careful of what you read. There's a lot of stuff out there that is suggestive that these are good treatments, but we may be doing harm. So in conclusion, really there's no obvious benefit to using polymyxin B or other therapies for cytokine reduction. Plasma exchange may be effective, but it needs to be confirmed in controlled trials. As I said, you can use it for rivaroxaban and possibly for rhabdomyolysis. But where are we headed? This is a blunderbuss therapy. This is where we're trying to mop up all of the nasty things. What we should be doing, and what does seem to be, there's a lot of research looking at this, is actually more focused treatments. And for those of you that have been involved in ABO incompatible transplantation, we've got these columns now that combined anti-A and anti-B. And so you've got a way that you can plasma separate, run your plasma past a membrane that's able to mop up, like flypaper, mop up the things that you want to mop up, and then you reinfuse that fluid. And this is it's taken out. This is from Russia. It's not a great study, but they have this device that's able to mop up lipopolysaccharide, and certainly showed that recovery from shock was better. There seemed to be an improvement in the group in terms of survival, but it's a very small study. But it's just guiding us towards ways that we maybe can be more targeted. And the thought is that what we're probably going to do is we're going to have some way of, we will measure things like endotoxin. If the patient's got a very high level of endotoxin, might be able to use a membrane that binds endotoxin for a short period of time, gets rid of it, and that has an overall beneficial effect on the patient. But still needs to be assessed as to whether exposure to the extracorporeal circuit is not more detrimental to the patient. And again, this is just another targeted therapy. This is looking at something which binds complement factor 5A, interleukin 6 and endotoxin, again showing improved scores. Now, my final thing is just looking at extracorporeal carbon dioxide removal, because this is also being used for patients in ICU. And the theory behind it is that you can actually put this into your CVVH circuit. You can remove carbon dioxide, and in doing so, you may well be able to reduce the amount of ventilation. So you might not have to ventilate the patients as hard, therefore reducing the amount of lung injury, and that may have a beneficial outcome. Unfortunately, though, it hasn't been shown to be that beneficial. This was a big randomized controlled trial. They were trying to rest the lungs, use smaller volumes, and unfortunately, 90-day survival was no different between the two groups. The need for ECMO was no different. ICU length of stay nor hospital length of stay was different. The only thing that was slightly different was that the duration of ventilation was ventilator-free days was actually slightly higher in the patients on the ventilation alone group compared to the extracorporeal carbon dioxide removal. So I'm sorry to have given a talk that's actually very pessimistic, because We all are always looking for something which is going to make our patients better. But I hope I've just made you think about how you appraise these new therapies that are coming out, and just think twice before embarking on it, because it's got theoretical benefit and a scientific background. We do need to know whether it really does have an impact on outcome. And just remember that your extracorporeal circuits are not biocompatible, and that's why these therapies may not work. It also might be why PD is not such a bad idea. And I think we just need to wait for some bigger trials to come out. I think TPE is going to probably be the way forward. Certainly I'll be glad to see that coming through. It's something that we know how to do. It's something we can do very rapidly, but the jury's still out. So thank you very much, and I'm happy to take any questions.
Thank you very much, Prof, for that very insightful, literally out-of-the-box presentation. I believe that most of us only knew dialysis is for, acute or chronic kidney disease, and that's basically it. So thank you very much for that. And I think a take-home message from my side is that what we have is what we should work with. I know that there are many companies that come through and suggest different filters, etc., for patients with sepsis, as you mentioned, the heme absorption and all. And they would present it in like this is a miraculous treatment and sort everything out. Given your talk, it just goes to show that you need to look at the bigger picture before you make any sort of decision. And I think that is important. For everyone on this call, at least, to keep in mind. Yeah. So just I don't see any questions in the chat box or in the Q&A. I'm not sure. Okay, there is one. Right. Dr. Akrabi from Kilimanjaro. She asks, is there a role of heme absorption in organ preservation prior to disease transplantation?
I'm afraid I have not seen any evidence for that, and it's I'm not aware of that. I'm not sure of the rationale, but again, no, I haven't been involved in that. We don't do it in our donors, but there might be something that I haven't seen. I know that I can see that I saw that Minyo McCulloch was online, whether there's something from the pediatric transplant group, but I'm not aware of it. Sorry.
Thank you, Prof. Prof. Mignon, you can speak.
Hi there.
Hi,
Great talk, Brett. I was just saying sometimes what we do well, we should maybe stick to. And I was really hoping that you'd come up with a golden bullet, but fortunately for us, nothing yet. We haven't had anything in peds to answer the question from Kilimanjaro. I think we usually try and follow what the adults do. Not often adult guys will follow what we're doing, but for organ preservation, nothing that we're using differently. But I must say it is good news to hear that maybe plasmapheresis may be the way forward, but it's so difficult in kids to get decent access, to get decent flows and stuff, specifically small children. I've got 2 children with HUS at the moment, and one is on hemo and one is on PD, and the young man on PD, it's just a much easier ride than it is on hemo. And so I think after listening to your talk, I'm going to stick to doing what I do best and what's easiest in pediatrics. I know adults it's slightly easier, but in kids, I must say PD when it works is really fantastic. And the reason the girl is on hemo is because we tried with about 3 or 4 catheters and it didn't work. So yeah, I think you need to, and often I think in Africa we think we're not doing as well because we're not doing all the fancy stuff, but sometimes the basic stuff really does work well.
All right.
I mean, I think the one thing that I would be slightly just thinking about the organ preservation side of things, I would be a little bit concerned that we might get microvascular changes. So might it have a benefit on the kidney or worsening the kidney? I don't know.
Thanks. So just a comment here from Dr. Amar, who is one of our nephrologist colleagues. He says an ampoule of polymyxin B costs around $40 in Tanzania. Dr. Lloyd is asking hemoperfusion with surface modification for adsorption and membrane modification, pore size or density. Where should the research focus on?
It's put wrong, but I think what I mean to say is where should now the research focus on? I mean, we've gone through the whole, all these things now, so we know something about everything. So where should the research focus on? Because I think membrane, ultimately, there's a lot to play on the membrane, whether it be the membrane surface modification, whether it be the pores and pore size and pore density, and depending on the therapy and the different modalities that we use. So where should the research focus on now?
Yeah, so I mean, look, I think so. If you look at pore size, so there was a trend towards using these high cutoff filter membranes in sepsis, because again, it was thought you could clear toxin. That showed improvements in noradrenaline requirements, but again, no benefit in survival. So the large pore size, I'm not sure that that's beneficial, unless you are replacing the good stuff. And that's again where you're coming into this idea of plasma exchange. In terms of hemadsorption is helpful, and I think that's where the Oxiris membranes, in our patients who have got acute kidney injury, who we already have on an extracorporeal circuit, certainly hemadsorption is something quite nice that we could use. It does bind lipopolysaccharide. So I think adsorption, I think there's still a lot to be looked at on that. But as I said, I think that we need to be looking at specific adsorption molecules. So where we can target a molecule that we're binding, not this big shotgun approach where we just bind everything.
Right.
Thank you so much.
Thanks, Prof. Thanks, Dr. Lloyd. Not sure if any of our other panelists have got questions. I don't see any questions in the Q&A. I would like to thank you very much for coming on today, for giving this expert talk on dialysis outside the box. It was very insightful, and I think the take-home message again is let's do what we do best, as Prof. Mignon said. And this webinar will be uploaded on our YouTube channel. And we would appreciate, Prof, if you could come back again sometime in the near future for another talk, perhaps on PD and how to establish PD in Tanzania, or at least East Africa. I know this is something that is on a lot of nephrologists' wish list, especially us who have trained in South Africa, where there is a PD first policy. We would like to have more PD seen in both our inpatient and in our outpatient setting. So perhaps maybe that is something we can do for the future. Let me just see one or two questions that popped up while we are coming off, if you don't mind, Prof. What can we say about future CKD treatment? That is one of the questions. And then the second question is HDF versus HD. What's your preference?
Is this in CKD or in so if you're talking in acute kidney injury in the patients on dialysis, certainly I do hemodiafiltration. I do prefer that. You do have a slightly increased risk of filter clotting with hemodiafiltration versus hemodialysis, and you've got less filter clotting than you do with hemofiltration. So I typically do hemodiafiltration with about a 50-50 split, usually with about a 30% pre-dialysis pre-dilution and 70% post-dilution.
Thank you, Prof. I think one attendee would like to talk. Dr. Shimola, you can go ahead. Your hand is up.
Sorry, it was a great presentation. Yeah, it's a great presentation. Here now, I think this is the time now we have to see, because we are seeing many cases in the whole country, and now with emerging new knowledge on PD, we know that in Tanzania we are very far. We don't do it much as our colleagues in South Africa and other parts of the world. And I think this is a highlighting is a highlighting phenomenon. Now I think you see, Dr. Maza, you remember in our country, some far 1,000 kilometers from Dar es Salaam, there are areas that we think with the issue of costs and the efficiency of the PD, the way it has been, it is going to be a game changer. I think now is the time now, we as a nephrologist, we have to make a plan, at least which can enable the government at least to change some few policies, at least to manage, to make sure that this is going to be implemented. That's just my comment. Otherwise, it's an eye opener and it's a game changer if we're going to interpret in the real life. Thank you very much.
Thank you so much, Dr. Shimola. Dr.
And
Shimola
with that,
is
I would like to just invite you all. I'm going to keep reminding you, but we've got the ISPD Congress in Cape Town next year, in September. So certainly, we'd love to see all of you there.
thank you, Prof.
Thank you very much.
Dr. Shimola is a nephrologist, but also the registrar for the private hospital accreditation body. He's in the government and looking through all private hospitals and making sure the quality of care for chronic kidney patients on dialysis is up to standard and per government guidelines. And hence the discussion about PD, it should be introduced as well. So that's why he had that comment. Perhaps maybe one last question, Prof, from Dr. Alfred Meremo. He's also a nephrologist. He also trained in South Africa at the University of Cape Town. Wits University with Prof Naika. And he is asking any ideas on current trends in heme adsorption treatment for critically ill patients in sub-Saharan Africa. Are we moving forward?
So I think heme adsorption in sub-Saharan Africa, I think not. I think we can spend our money far better on other things, better antibiotics. You're going to do far better if you measure your antibiotic therapeutic levels than you are by heme absorbing someone. So I think for now, stick with, as Minion said, stick with what you do well. Look at treatments that are well proven to improve outcome in sepsis, and things may change, but I wouldn't be rushing that way.
Yeah, I mean, there's one thing I think Dr. Shimola actually pointed that out. So we actually are very keen to actually start PD in East Africa. We actually have been negotiating to bring in PD fluid. So I just wanted an opinion as to how best we can make it cost effective to put it in, so the governments can afford to deliver this, allow us to actually bring PD fluid, and so it can be effective to serve people in the rural communities, from your expertise and your position, Dr. Cullis.
Yeah, so I mean, yeah, this is always a big debate as to costs. The first thing to look at is what are the real costs. So PD fluid is expensive when it's being imported, but it's actually expensive in South Africa where it's made locally. A lot of people say local production will bring the price down. It doesn't generally do that. Where there's been a huge impact has been places like Thailand, where the government decided that PD was the way forward. And so the government negotiated the rates for the PD fluids on the basis of there being obviously a higher proportion of patients going on to PD, but also the government having an impact on tariffs or import tax. So it is very important if we can get the government's buy-in to look at it from that side. And there's a number of papers from Thailand, just showing how they did it and how collective bargaining makes a big difference. And certainly I'm very keen. We're hoping to hold a policy forum in Cape Town at the ISPD meeting, where I'm hoping to get the Director Generals from all the sort of sub-Saharan African countries together to look at whether we can't create an African consortium where we are actually creating a bargaining chamber for PD fluid. So I think that's one key aspect. The other thing is that I would I would urge you to have a look. There's a paper that was published at the beginning of this year out of Johannesburg, looking at the costs of PD versus hemodialysis in chronic patients, showing that it is actually significantly cheaper than hemodialysis when you take into account all the factors, patient transport, electricity, water, all of those things. And also, there's another paper by the same group showing the benefit in terms of economic productivity of patients on PD compared to patients on hemodialysis, again in Africa. So there's two nice economic studies that have been published, which again are worth having when in showing it to another African government to say, you know, actually it's not too bad.
In terms of exchanges that you would propose, yes, ideally, yes, you can go a lot of exchanges, but at least a minimum number of exchanges where, you know, a reimbursement could be possible, and survival is also, you know.
Yeah, the other thing to also be aware, so incremental PD, where you are starting patients on less dialysis than 4 bags a day, for example, is significantly cheaper than hemodialysis. And you can often manage patients for quite a while, up to sort of 1 to 2 years, on much less fluid than 4 bags a day. So, and in doing so, I mean, you can find a study to support either viewpoint, but the feeling is that you probably do preserve residual renal function a bit longer by doing that compared to putting them on hemo. So you get a little bit of a lead time with those patients where you're not spending as much on their dialysis. What's important though is that it's not used as the risk is that you say, well, look, we're going to put patients on 2 or 3 bags a day. And the government says, okay, well, that's fine. You can have 2 or 3 bags a day. You then have suboptimal dialysis. Patients do badly. PD gets a bad name. And then it all falls down. So, you know, it needs to be incremental dialysis, not low volume dialysis. You know, you increment as they lose their residual function.
Thank you very much.
Thank you very much, Prof. As you can see, PD is a hot topic, and I would really welcome you to one of our other talks sometime probably this year. And hopefully we're looking forward to being able to join you at the ISPD Congress next year in Cape Town. Thank you very much, and I wish you a very good evening, and good evening to all the participants and everybody that asked questions. Thank you very much, Prof. Really appreciate it.